Vascular cognitive impairment and dementia refers to cognitive decline caused by cerebrovascular disease, including both symptomatic and silent strokes. It is the second most common cause of dementia after Alzheimer's disease and frequently coexists as mixed pathology. Mixed dementias are the rule rather than the exception, with vascular and neurodegenerative processes often overlapping. Approximately 50% of stroke survivors develop cognitive impairment, which often worsens over time. Even silent cerebrovascular lesions, detected on magnetic resonance imaging, contribute cumulatively to cognitive decline. Large cerebral strokes cause cognitive impairment depending on lesion size and anatomical location. Strategic infarcts in the thalamus, medial temporal cortex, anterior corpus callosum, or angular gyrus can produce memory-dominant dementia. Multiple strokes significantly increase the likelihood of cognitive dysfunction and accelerate decline. Cerebral small vessel disease is a major contributor, driven by arteriolosclerosis and cerebral amyloid angiopathy. Arteriolosclerosis involves thickening of small vessels due to plasma protein leakage, associated with hypertension and diabetes mellitus. Cerebral amyloid angiopathy involves beta amyloid deposition in vessel walls, predominantly affecting lobar cortical regions. Magnetic resonance imaging reveals lacunar infarcts measuring 3 to 15 millimeters with characteristic fluid attenuated inversion recovery patterns. Microinfarcts are smaller than 3 millimeters and often remain invisible on chronic imaging. Microbleeds appear as hypointensities on T2 star weighted imaging, with deep lesions suggesting arteriolosclerosis and lobar lesions suggesting amyloid angiopathy. White matter hyperintensities reflect diffuse gliosis and demyelination and correlate with cognitive decline. Severe white matter disease leads to Binswanger disease, also known as subcortical arteriosclerotic encephalopathy. Vascular pathology often coexists with Alzheimer's disease through mechanisms such as blood-brain barrier disruption. Impaired clearance of beta amyloid through perivascular pathways further contributes to neurodegeneration. Evaluation requires identifying vascular risk factors including hypertension, diabetes, dyslipidemia, smoking, and atrial fibrillation. A history of prior stroke or transient ischemic attack supports a vascular etiology. Clinical course may show gradual memory decline or a stepwise deterioration following vascular events. Brain magnetic resonance imaging with fluid attenuated inversion recovery, diffusion-weighted imaging, and T2 star sequences is essential. Treatment focuses on primary stroke prevention with strict control of blood pressure, cholesterol, and blood glucose. Blood pressure targets are less than 140 over 90 millimeters of mercury, or less than 130 over 80 in high-risk patients. Antiplatelets and statins should be considered when imaging suggests embolic or large vessel disease. All patients with asymptomatic infarcts should be screened for atrial fibrillation. Cholinesterase inhibitors such as donepezil, rivastigmine, and galantamine may provide modest benefit in mild to moderate impairment. Memantine or high-dose donepezil can be used in moderate to severe cases with shared decision-making. Clinical takeaway is that vascular dementia results from cumulative cerebrovascular injury and requires aggressive risk factor control to prevent progression.